In the pre-Copernican world, the heart was the center of the universe, sort of like the Earth was the center of the solar system. Well, that's not true. We know that the Earth is actually a secondary body, orbiting around the. We ready to go? Ready. Orbiting around the sun, and to make yourself not the center of the world is an extremely difficult thing to do, especially if you're an adolescent world, as we were. But in the circulation, this is even more true. The heart is the handmaid of the circulation. Though if the heart doesn't pump, you are clearly dead. The heart cannot in any way whatsoever determine cardiac output. Its only job in life is to keep the right atrial pressure as low as possible so as to allow the maximum amount of blood flow back as it can, and to sustain a mean arterial pressure so that the body can have blood flow. It does nothing else. The determinants of everything else are done by the rest of the body. And today we're going to talk about the arterial side of it, okay? So let's see if this thing works. So I'm going to ask you a question. I told you I'd ask you a question. Why do warm-blooded animals have a high systemic blood pressure? It's a very expensive trait. It requires increased muscular pumping. So if your coronary arteries have stenosis in it, you can have ischemia and infarction. It stresses the arterial conduits. That's why we get atherosclerosis and aneurysms. And if you have congenital aneurysms, they can rupture. And furthermore, after a while, you'll get into organ dysfunction in the heart, the brain, and the kidneys. And these are all true statements. So why do you have a high blood pressure? I'll ask you this.
Metabolic demand?
No, so thank you for playing. I can give an animal reserpine to take away their adrenergic activity of the sympathetic nervous system. So if I reserpinize an animal and give it fluid, it can have a mean arterial pressure of 30. And fluid resuscitated will have a cardiac output this high. And its mean arterial pressure is 30. It will not have hyperlacticemia. It will be peeing. It can eat. It can think. Okay? Right? A worm has a mean arterial pressure of 4 to 5 millimeters of mercury. Don't ask me how I know. So the point is that I can have blood flow to meet the metabolic demands of the body with a profoundly low blood pressure. Okay? Again, so that's not the right answer. The reason that we have a high mean arterial pressure is to regulate blood flow. What we have is a high organ resistance, which is the arteriolar tone out in the periphery and the precapillaries. And we have a tissue interstitial pressure. And we have a high input pressure in the aorta. And the primary method by which you increase the blood flow to your gut after you ate your sandwich just now, or if you're thinking and you want to increase cerebral blood flow, actually cerebral blood flow goes up if you're thinking, is by selectively vasodilating the high resistance arterioles in those vascular beds that have increased metabolic demand so that there will be increased blood flow. Cardiac output within this context, and this is very important, is only important to maintain blood pressure. The body defends blood pressure, not cardiac output, period. The brain, the kidney, the heart, every organ can care less what cardiac output is. They only care what organ perfusion pressure is. Well, what's the rationale for the defense of arterial pressure? It allows for the autoregulation of blood flow distribution. I do not have to invent septic shock to abolish autoregulation. All I have to do is be hypotensive, and I cannot have increased blood flow to those organs that need it. Because if I'm profoundly hypotensive, if I vasodilate up my cerebral arteries to get more blood flow, if there's no blood pressure, there's not going to be any more flow. So hypotension abolishes autoregulation. Now, sepsis does that too, don't get me wrong, but I don't need sepsis to abolish autoregulation. All I need is hypotension. Hypotension's a medical emergency. You die if you're hypotensive because you do not get blood flow to your heart and brain. Well, we have a problem. Left ventricular ejection is phasing. How do I get a constant arterial pressure when, because I don't have a centripetal pump, I've got a heart that's going like this, okay? Well, what I would do if I were making the system is I'd have that pump into a capacitor that could swell up and increase its pressure and charge. And during the time the pump's not working, which I'll call diastole, I would allow the capacitor to discharge that volume so that it constantly, at all times, it'd be flowing out of this, okay? And so what I would do is I'd create what's called a wind kessel, which is a air pump. You know what a wind kessel is? Ever heard that term? Did any of you guys ever see those old movies from the 30s about the firefighters from the turn of the century, and they would be running to the fires and they'd be on the side of these wagons and be pumping back and forth in wagons? You ever remember those pictures? No? Yeah. And you saw the hose out the end and the water was coming out like that. Well, what they were doing was they were using a air pump. They had a big wagon filled up with a barrel in it. And the barrel was covered on the inside with copper. And they filled it with water. And then they used this pump on the side to pump air to pressurize the top of this water with air inside the cylinder so that it would be pressurized. And at the bottom, a hose came out, a conduit, to a peripheral resistor, the nozzle. And if you watch the water coming out of the nozzle, it came out like this. Every time they pumped, it would go higher and then it would go down. And that's called a wind kessel. And that's the model we use to describe the circulation. Basically, we have a high central capacitance near arteries and a high output resistance. And then with each ejection, we cause the aorta to expand, and during diastole, the stroke volume comes out as flow. Okay? So we need to be able to assess this phasic effect on arterial tone. And the ways we assess arterial tone is to look at blood flow under pressure, and that is specifically resistance and the critical closing pressure. And I'm going to go through all these points. But the flow is not steady state. It's not continuous flow. And resistance assumes that you have a continuous flow, which is not at all what our circulation is. It's phasing. Okay? Look in the arteries of the eye when you're doing a pulmonologic exam. You'll see it's phasically going. In the lungs, blood flow is like this. Okay? So what you really want to do is look at phasic flow. And phasic flow is appropriately measured by elastance, impedance, and inertance. And I'll show you that we can measure that easier at the bedside than resistance. Okay? And I'll show you it's easier. And then finally, how flow occurs is a function of its characteristics, whether it's turbulent, laminar, etc. Is this even important? You bet it is. Anybody here take care of post-op patients? They're cold, their blood pressure is normal, and then they warm up and their blood pressure falls? They didn't have a fall in blood pressure because of vasodilation. They had a fall in blood pressure because when your temperature gets warm, the viscosity of the blood falls. And therefore, for the same resistance, your blood pressure goes down. So your post-op hearts that warm up and they lose their blood pressure, they're not vasodilating. It's just loss of viscosity. Okay? All right. What are the determinants of arterial pressure and flow? Well, it's the resistance, the impedance, and ventricular arterial coupling, and that's what I'm going to talk about clinically for the next 15 or 45 minutes. So let's start with this thing first. You know what chain-stoked respiration is, right? Yes? No? Anybody here not know what it is? Chain-stoked respiration is you start to breathe in, your CO2 falls, so you stop breathing as much. But then as you stop breathing, the CO2 rises and your brain says, oh, the CO2 is going up and makes you breathe faster. Well, it's the exact same concept with baroreceptors and blood pressure and flow. We have Meyer waves, which are chain-stoked respirations. And what you see in any one of your patients, go into any ICU right now in any one of your patients and have your arterial pressure waveform that scans across the screen slowed down to 30 seconds. You're not used to seeing it that way. But if you did, you would see that it actually goes in a sinusoidal wave. And what it is that when the blood pressure is down, your baroreceptors say, I'm in trouble, and increase the sympathetic tone, as you see. And the blood pressure goes up, but cardiac output goes down. And as your blood pressure goes up, it pulls away sympathetic tone, and the blood pressure goes down. And thus, when you ask the nurse or the doctor at the bedside, what is the mean arterial pressure, systolic, diastolic, and mean, they shouldn't give you a single value because the value is going to oscillate between these points. Now, I think I told this joke once before that if a nurse wants you to give a volume to a patient, she'll report the lower value. If the nurse thinks that the volume she's given is more than adequate, she'll report the upper value. And that, of course, is part of the editorializing we do in medicine. But the fact of the matter is that this is normal. Plus or minus 5 millimeters of mercury, mean arterial pressure, is you being a normal human being. And this occurs at a frequency of about 8 to 10 times a minute. Okay, what is arterial resistance? Well, by Ohm's law, resistance is equal to pressure divided by flow. If the resistance is higher, I need more pressure for the same flow. Okay? And it's, unfortunately, it assumes a constant pressure drop across the circuit because Ohm's law was meant for electrical current, and it was for DC current. And if you looked at the current power at this part of a copper wire and that part of a copper wire, you would actually see that the actual voltage falls as you go down the wire because it gets lost in the energy necessary to go down the electrical wire. And the amount it falls is the resistance of that wire. That's Ohm's law, okay? It assumes a constant flow as well, okay? And the methods that we look at it is the arterial pressure-flow relationships and an evil thing called systemic vascular resistance, which I don't want you to use in my presence, okay? Don't use that term. It doesn't exist. So, this is basically the principle, that the slope of this line is resistance, and as the pressure falls from the left ventricle to the central venous pressure, it's a linear fall. Is that true? The answer is no. This is data from a human being collected in the 1970s by Milnor from Johns Hopkins in the cath lab, in which he measured in the aorta of human beings and followed the pressure, pulse pressure, all the way out to the periphery. And then he came back from the other side as far up as he could go. As you can see, if you were to look at the resistance is totally focusing on your arterioles and precapillary sphincters. I want to show you something else. There is no resistance in your arteries. There is no arterial resistance at all. If there were, you couldn't use radial artery pressure to measure mean arterial pressure because it would be lower than your aortic pressure. Yes? I mean, you knew that, I think, but you just didn't realize it. All of these, the aorta, the descending aorta, femoral veins down to the profundas, and all the way to your radial arteries are one massive capacitor that every time you take your stroke volume, you just fill it up with more blood. And then it drains from that during diastole into wherever the low resistance circuits are, like the kidney, the gut, the heart, and the brain. If you were to put a flow probe, lie one of you guys down, put a flow probe on your femoral artery, you would see that during diastole, flow would be back up towards the brain because this is just a great big capacity. My stroke volume, as measured 2 days ago, and Mohammed was there when they measured it, was 75 mLs per beat. Okay? How much volume is 75 mLs? How much? Is this as much as in that beaker? It's like your beaker. I promise not. Is it even the amount of volume that's at the bottom of this beaker? That's like 150 mLs. It's only a little bit of volume. So let's go. If I were to make my aortic arch, and I were to inject 75 mLs into the aortic arch, how much volume do you think that is? Just about to here. So that stroke volume just goes here. So the stroke distance is about 15 centimeters. Just in case you want to know what the road. So every 15 centimeters, the blood's going down. It's not whoosh, whoosh. I'm just giving you physics, right? You understand, what's the stroke volume? What's the volume here? So you're never, ever flowing the blood. All you do is charging this capacitor. You understand? And that's what you're seeing. So what happens is you're charging this capacitor. And then the flow comes to this point here, which is your arterioles and precapillary sphincters. And then all of a sudden, there's this massive fall down. This is your critical closing pressure. And you can't even measure the pressure here. And the next time you can measure it, you're measuring the effective circulating blood volumes pressure, the mean systemic pressure, which we'll discuss in the next lecture. And that's your resistance. So there's absolutely no way in the world that your arterial circuit behaves like a continuous pressure fall over time. Arterial resistance, I think you'll all agree, therefore, is not linearly related across the arterial circuit. Is that clear? Good. Okay. Well, we went into the operating room, took human beings, split open their chest, put an aortic flow probe on human beings, put our finger on the inferior vena cava, and measured not only arterial pressure, but aortic stroke volume using an aortic flow probe, which is the gold standard. This is an IRB-approved protocol that took us 3 years to recruit 7 patients, and you cannot believe the consent form for this. It was amazing. Of course, we were doing it right before cardiopulmonary bypass, and nobody had any complications. But it's the first and only time ever anyone ever measured legitimate gold standard, perfect flow in the aorta versus pulse pressure. What we found was that in every single patient, there was an extremely tight linear relationship between the stroke volume that they had and their pulse pressure for that beat. So we know that the pulse pressure is determined by stroke volume, but look at the slopes of the lines. Everyone has a different relationship because the capacitance, the impedance of their central arteries are different. But the pulse pressure is determined by the stroke volume. Okay? So one of the ways to look at it, and the way that the American Physiologic Society says that we need to define arterial resistance, and I agree completely with this, is not by the mean arterial pressure and the cardiac output, but the change in pressure to the change in flow. That slope of the line is resistance. Actually, you'd have to reverse it for cardiac output down here, and arterial pressure on the y-axis, and then the slope of the line is resistance. This is the reciprocal of the slope of the line. So resistance is equal, this doesn't work on the screen, resistance is equal to pressure divided by flow, but it's a delta pressure flow, so it's not the absolute pressure to flow, okay? So if you have a patient and you know their cardiac output and their mean arterial pressure, and you give them volume, and you get a change in cardiac output and mean arterial pressure, you can look at the delta of those two and calculate resistance. But what I want to show you, and this is true in all of us, is that if I were to extrapolate down this line, I would not go to 0 mean arterial pressure. I would go to an arterial pressure that's much, much higher than 0. And this pressure is called the pressure of zero flow. Okay. So let's assume I take you, and I put an art line in you, in the radial artery. And then I blow up a blood pressure cuff on your arm, but I blow it up so fast that you only had time for 1 heartbeat or something, so there's no change in the blood volume in your hand, okay? And of course, I would immediately see that the pulsatility of the arterial catheter will go away, right? Because I blew up a blood pressure cuff. Right? And you can do this, by the way, any ICU you want today. You go right after, leave me. Go to the ICU and do this. Tell the nurse beforehand you're doing it because they get upset when the blood pressure falls, okay? And what you'll see is it will not fall to 0. It'll fall to about 45 to 50 millimeters of mercury. Instantaneously, it'll subsequently, over another 30 seconds, fall to the mean systemic pressure, and I'll show you that lecture tomorrow, in a week. But what you're going to see is it's actually going to fall to that real back pressure that the body sees. Your really arterial resistance back pressure isn't CVP. It's somewhere like 45 millimeters of mercury. And you can prove it yourself anytime you want if you have a patient with an art line in. Okay? Don't have to believe me. Okay? So if I have an increase in resistance, then by definition I need a higher amount of pressure for the same amount of flow. And if I have an increase in resistance, then I have a much less pressure needed for the increase in flow, right? That makes sense, okay? So there's a fallacy of the use of CVP. Systemic vascular resistance. Systemic vascular resistance is calculated as mean arterial pressure minus CVP is the pressure gradient divided by cardiac output. Well, I was 1981. Hopefully some of you were born by then. I was the attending in the medical ICU at the Oakland VA up the hill. And I was woken up at, this is a true story, I was woken up sometime at night, and I will say 3 in the morning, but I have no idea. And it was my resident. He said, Dr. Pinsky, Mr. whatever, Schwartz, is going into septic shock. Shoot, I said, or something like that. Tell me about it. Well, remember you told me to give him volume. I said, yes. He said the systemic vascular resistance halved. So we're drawing cultures and we're going to give him antibiotics. I said, okay. What happened to his blood pressure? He said, it was normal. Mean was 85 and it didn't change. I said, what happened to his cardiac output? It doubled. I said, that's the normal response of a person who's hypovolemic to getting fluids. I'll talk to you in the morning. I hung up. he calculated the systemic vascular resistance. And if the mean arterial pressure doesn't change and the cardiac output goes up, then your vascular resistance by definition goes down. Okay, you understand what I just said? So watch. He calculated this slope, and he gave the volume, and he showed that the slope went up or the resistance went down. And the fallacy with that is that that's a pre and post, is that there was no change at all in the resistance. The slope was just flipped over here. Okay? The slope is worse, so the guy has, it appears he's vasodilating when he isn't. Let me show you, this is coming out in Anesthesia and Analgesia sometime this year. I haven't seen the galley proofs, but I know it's coming out in 2012. We did this in humans. I'm the senior author of this paper. Basically what we did is a series of inspiratory hole maneuvers. This is your airway pressure. And we measured instantaneously cardiac output using an arterial pulse contour device, which I think I'll tell you about in a couple of weeks. And you can see here the arterial pressure falls. This is radial artery pressure. This is where it was before. And here's the inspiratory hole value. You can see the cardiac output on a beat-to-beat basis is up here and it falls down to here. Well, if we do a series of those, you can see there's your cardiac output. Here's your cardiac output here. And here's your mean arterial pressure. And you can see that you can extrapolate those down, and it behaves as if this is a human being. This is post-op surgery patients. It behaves as if the critical closing pressure is, in this case, 35 millimeters of mercury, not CVP. Okay, this is normal. So let's think about that. We then looked at what was the resistance of the curve. This is all the patients now versus systemic vascular resistance. This is the line of the two. They co-vary, but look, the closer your real resistance comes to zero, the more systemic vascular resistance and arterial resistance is the same. What does that mean? Well, that means that if you think about it, what's really happening is the degree to which your pressure zero flow becomes closer and closer to right atrial pressure, well, of course they're going to be the same line. Okay? When would we expect a low pressure and zero flow? When you're totally vasodilated. Liver failure patients, septic shock. Okay? And then there's very little difference between true arterial resistance and systemic vascular resistance. But once again, systemic vascular resistance is inaccurate. Well, we showed in 1986 that when you give acute endotoxemia to a dog, you got a parallel shift of this pressure flow relationship, which was associated with a decrease in your precapillary sphincter. Why? Because endotoxin causes the loss of precapillary sphincter tone, the periphery dilates up. You might want to sit here so you can see better. And then finally, Petros showed a little later that after about 6 hours of endotoxemia, you get actually a decrease in resistance as inducible nitric oxide synthetase is made. And these are the data from that study. Here's baseline. And what we found initially was that the curve was shifted to the red one and then subsequently to the pink. So let me give you a clinical scenario which I'm sure you've heard in your life. You're called by the nurse, and we're going to have this poor Mr. Schwartz again. Okay? Poor man. Mr. Schwartz was 3 days post-op, and he spilled his abdomen a bit, but he was doing fine. He was going to come off the ventilator, and you started to take him off the ventilator. He's a little tachycardic, etc., but he looked fine otherwise, and so you extubated him. He's been a little tachycardic. And the nurse calls you now, and you're at a conference with Quincy, and she says, Mr. Schwartz became hypotensive right now. And you say, give him a liter of saline, and I'll come over and see him. And you say, I got to leave. Okay. And you give them a liter of saline, and their blood pressure comes up. So you come back to the conference room, and then later on that night, they say, Mr. Schwartz is hypotensive again. You say, give him a liter of saline again. They said, we already did another one, and it didn't work. You got to start norepinephrine. Have you heard that scenario? All the time. What's happening? The first one is the initial effect of shock is to lose precapillary sphincter tone, but your resistance hasn't changed. You give that person volume, their blood pressure will go up with the increase in cardiac output. But later, when the shock has established a vasodilating effect, the cardiac output will still go up. It's not that they're not volume responsive, but their blood pressure will not. They need norepinephrine at this point to get the blood pressure up. And why do I need norepinephrine? Because I want to maintain autoregulation of blood flow distribution. Isn't that clear? Okay, good. So So now let's talk about what is this pressure is zero flow, this PZF. Well, think of it this way. As the blood flows down the arteries to the arterioles, to the precapillary sphincters, the actual surface area or volume in the vasculature markedly decreases until it gets to this high place in the precapillary sphincter where the critical closing pressure of the capillary sphincter functions like a Starling resistor. And that's really nozzling it like you have this jet nozzle on the end of a hose, squirting out really fast. But where does it end up at the other side? It falls then into this totally compliant, essentially infinite capacitance capillary bed with no resistance. And so it just falls away. It's like putting that nozzle into the top of a swimming pool or the ocean. You're not going to change the flow one bit. Because the pressure drop from there to the ocean is whatever the pressure is. And we call that a waterfall. Why do we call these waterfalls? Because watch. If I've got water coming to an edge, and it's now going to go over the waterfall, and it goes over at a rate of 10 liters a minute, okay, the water, and it's falling down this far, and I take the pan it's in, and I pull it up so the pan is here, it's still going over the waterfall. How fast is it going to go over the waterfall now? 10 liters a minute. But my back pressure has gone up by 100 millimeters of mercury. Doesn't matter. It's on the other side of the waterfall. Unless I make that pressure higher than the waterfall threshold, the back pressure is meaningless, right? Water falls over the waterfall at the same rate whether it falls 5 inches or 5 miles. Doesn't matter. So vascular waterfalls mean that the downstream pressure is not what you're measuring venous-wise. It's what you're measuring at the vasculature. Now, you know that in the lungs, if you're in zone 2 conditions, it's alveolar pressure is your vascular waterfall, right? And you can raise and lower left atrial pressure all you want as long as you're in zone 2 condition where alveolar pressure is higher than left atrial pressure. Your arterial resistance is from the pulmonary artery to the alveolar pressure. That's classic West zone 2. That's a vascular waterfall the same. Okay? I'm just showing you that there's consistency in the work. Okay. So let me show you some interesting data that shows how important this is to you and your patients. David Kramer, who is going to be our distinguished alumnus lecturer this year, who spent the last 12 or 14 years, I can't remember exactly, at the Mayo Clinic running the transplant service, just moved this year to Wisconsin to take over something like that. Was in my laboratory many years ago, before he left to become famous. And he measured the organ blood flow of the kidney, the gut, and the liver with hepatic, renal, and splanchnic flow probes in a dog model. And he did an IVC occlusion and showed how they rapidly decreased their input pressure, the arterial pressure, and flow. Okay, you with me? And he showed that the kidney has really low resistance, but you knew that, right? Kidney has very low resistance and has a relatively high critical closing pressure. The gut's in the middle, and the liver has a very high resistance, but a really low critical closing pressure. And you knew that as well because you know that liver transplant patients have to have a high mean arterial pressure to maintain hepatic arterial flow. If any of you are in PICU, you know that you maintain post-op a high mean arterial pressure. Just like those patients in the CT ICU who are coming back with left internal mammary artery grafts to their heart need a higher mean arterial pressure than just venous rate valves because there's a higher resistance in those vessels. So this is what you'd expect. But I want to show you something here. This is reality, but look, let's assume that this is my mean arterial pressure. And I do nothing but just decrease mean arterial pressure a fixed amount. Look at what happens to two things. Blood flow distribution goes down differently. I get a much greater decrease in renal blood flow than gut blood flow, and almost no decrease at all in hepatic blood flow. The kidney is a setup for ischemic, a hypotension-induced ischemia. That's why your kidneys check out when you're hypotensive. That's why your liver does not. Not seeing too many shock livers from hypotension. You see shock livers from increased CVP as the back pressure's in, but you don't see shock livers from hypotension. You see shock kidneys all the time. That's why. Is that clear? Isn't it simple? Okay. So the problem is you can't predict what the pressure is going to be. This is the perfusion pressure relative to link, and I schematize it. The hepatic artery, as you know, has a high resistance. The renal, unfortunately, has two arteries, one pre and post glomerulus. The portal vein is even worse because it goes from the mesenteric to the portal. So you cannot identify from the same mean arterial pressure, and this is an important concept. You do not know, if you know the mean arterial pressure, what the organ perfusion pressure is for all your organs, okay? Because they'll have different resistances as they go down. For the same mean arterial pressure, we know that a porta hepatis, for the same, let's say you have a mean arterial pressure of 90, your porta hepatis, if you were to put a catheter right then and say, what is the hepatic arterial pressure as the hepatic artery enters the liver? Now we have a mean arterial pressure of 90 or 100, it'll be 60. Because the hepatic artery has a high resistance on its own. It's uniquely that way. It's also very reactive, so that you maintain portal venous to hepatic arterial flow as a constant flow rate through the liver on a thing called the hepatic buffer response. So the fact of the matter is, knowing the mean arterial pressure doesn't tell you the perfusion pressure of your organs. Okay? It does tell you gross perfusion, and it will tell you the perfusion pressure, you know, intracranial pressure for the brain and for the heart. And those are the only two ones that really count if you're in the middle of resuscitation. But after that, you need to know intra-abdominal pressure and intrahepatic resistance if you want to know the kidney, the gut, and the liver. Okay? So let's assume I had a patient who had a cardiac output and mean arterial pressure that are here, and we find that the cardiac output went up, but the mean arterial pressure went down. What happened? Was this a decrease in resistance or a decrease in mean systemic pressure at zero flow? Did I decrease the resistance or did I have a parallel shift? You have absolutely no idea. And you couldn't possibly have any idea because both can do it. You have to then get volume, see if cardiac output goes up, and see what happens to pressure, and look at the change in pressure to flow. But I can help you because we can actually resolve that question easily. And that'll be the last part of my talk, and that's looking at ventricular arterial coupling. And I'll show you how today, when you go back, you can do this at the bedside. So let's go back and look at arterial tone. It's absolutely difficult to assess, even at the best of times. The reasons are that we don't know what's happening to organ perfusion. When your patient's hypotensive, is it due to loss of volume, which means they'll vasoconstrict and the resistance was high and the cardiac output's low? Is it due to sepsis, which may be a low cardiac output? You don't know. But definitely there's loss of resistance. You don't know. So at a single point in time, you see the patient, you do not know where they are. Do you understand how important that point is? You have to defend blood pressure because they'll die if that isn't the case, but you have no idea what cardiac output is. Okay? You need to define the pressure flow relationships. So when I come in and I jump on a patient, yes, I get the blood pressure up, but then I say, where the heck are we? Okay. What is our flow? What is our organ function? Because I can't possibly know it by knowing blood pressure. Is that important? Do you understand what I just said? Good. Great. Okay. Well, other factors also alter vascular resistance, and they're shown here. Probably the most important is blood viscosity. We talked about hematocrit, and obviously if your hematocrit's over 60 or so, you get such viscous stuff that you get inciting thrombosis. So we have those people become blood donors so that they keep their crits down. But the more important one is temperature. And vascular impedance is the other determinant, and we'll go into both of these in a second. When we look at the determinants of microvascular flow, the velocity of flow is equal to some constant, pi over 8, times the radius of curvature to the fourth power, times the length that you went, times 1 over the viscosity, times the driving pressure. And I've just rearranged Bernoulli's law. This is just kind of changing the structure to make. So I have a conductivity part, a rheological part, and a driving pressure part. I've already shown you the driving pressure part. Obviously, if the vessels have very small diameters, the resistance goes up massively because as the vessels get smaller and smaller, the resistance rises to the fourth power. Okay? But let's now look at viscosity. Viscosity is a function of hematocrit. When your hematocrit goes above about 45, it starts to get more and more viscous, which means for the same amount of flow, the pressure rises. But pretty much below 40, it doesn't affect you. But more importantly, we want to care about impedance. Impedance is the concept of dynamic pressure to flow, and it's a more accurate measure of the vasomotor tone than its resistance. And what it does is it matches pressure to flow, and it gives you the reason why you have a pulse pressure. and why the pulse pressure is different in the radial artery than the femoral artery than the aorta for the same human being at the same beat. Okay? So here, what I've got here is I've superimposed, this is from Milner's textbook, a aortic pressure signal and aortic flow signal. Now, obviously, one is in millimeters of mercury and the other is in liters per minute, and they're not the same. But if the arterial pressure was determined by flow alone, the two shapes should be identical. They're not. And in fact, what we have is an aortic pressure profile that cannot be accounted for by the flow. And this is because as the left ventricle ejects in and increases the flow into the aorta fills up and becomes stiffer. Okay? And so for even lesser and lesser flow, the pressure still rises. Okay? So this is an example of looking at the arterial pressure as we go from the ascending aorta way out to the equivalent of the radial artery. And this is how the flow is going. And as you see, the pulse pressure rises. The reason the pulse pressure rises as you go out in the periphery is because as the pressure wave, remember the flow doesn't go out that far. Remember I told you the flow only went this far? Are you with me? Flow only went this far for stroke volume. So the pressure didn't go all the way out there. I mean, the flow didn't go all the way, the pressure wave went out there. So the pressure wave goes out to the periphery, it hits those precapillary sphincters and arterioles and bounces back and summates with the ingoing pressure in such a way as to heighten this. And that's the reason why we get reflected pulse pressure, both systole and diastole here. But you'll note that the mean arterial pressure is the same. Oops. The mean arterial pressure across is the same because there is no resistance in your large arteries. So here, I want to show you a really pretty picture. This is a human being in cardiac cath in which they measured the arterial pressure waveform using a Millar catheter, which is a super high resolution catheter. And they put them all together exactly by the ECG, so the exact same point. 5 to 50 centimeters from the aortic valves. And you can clearly see that there's a pressure wave that goes down the aorta, right? And here's your dicrotic notch. But I'm going to show you to your own eyes right now, and I want you to look. I'm not going to do anything fancy. I'm going to show you right here. I can show you the major reflected waves as the blood comes down, bangs against the periphery, comes back and hits the heart as it's ejecting, gets shot back down, and then you'll hear the ringing. Are you ready? Are you ready? I'm showing you right here. Well, there's, of course, the drop of the aortic valve. So this could be considered to be a pulse wave. But here's your systolic wave. It bounces back, comes back again, bounces back, comes back again, bounces back. In no time did my hands even lick my body. Okay? This is, and I only showed you the major harmonic. There are hundreds of harmonics in this. This is normal. The body does this, okay? So, in fact, if you were to look, this is now on the front is the aorta, all the way back is the radial artery. This is an animal model, a baseline. And then what they did is they simply caused it to be hemorrhaged. And look at what happens, oops, sorry. Look at what happens to the pressure profile with hemorrhage. The reflected waves are so terrible, they screw it up. And then it comes back afterwards. So what you're seeing in the periphery is not the arterial pulse, but it's a combination of the arterial pulse plus the impedance characteristic of the circuit, which can be totally screwed up if you have vasoconstricted and totally lost if you have sepsis. Okay? That's why you often see a profoundly dampened pulse on people with sepsis and why you see a heightened pulse on people which are hyperdynamic, where you've just given them epi for a cardiac arrest. Okay? So, arterial input impedance is a very difficult physiologic concept to use at the bedside. I publish on this, but I don't expect you to do it. It's clinically not useful. What I can use is I can use ventricular arterial coupling. And that's a nicer way to look at it. And that is matching arterial elastance to ventricular volume. Now you have to go back and remember my last lecture on left ventricular function and the pressure volume loops, okay? Remember that lecture? Okay. So if I have a given stroke volume, it gives me a mean arterial pressure. You with me so far? And also gives me a mean pulse pressure. And if I increase my stroke volume, I'll increase my pressure. But if I have no stroke volume, and I look at what the pressure fell to, remember the blood pressure cuff on the arm? It doesn't fall to zero. It falls to some critical closing pressure. What I'm describing is the arterial elastance. This is the beat-to-beat characteristic. This is what your body really sees. This is what your heart sees when it beats. And that is its relationship to dynamic accelerations and pressure caused by stroke volume. Okay? So within this context, if for the same stroke volume, arterial pressure is less, I must have a decreased arterial elastance. And for the same stroke volume, if the arterial pressure is more, I must have an increased arterial elastance. And this is not physiology. This is physics. This is how we define the world. This has to be true. Okay? So just by looking at stroke volume and pulse pressure, I can know what's happening to my patient instantaneously on a beat-to-beat basis. Okay? We have minimally invasive pulse contour analysis. We have esophageal Doppler. We have NICOM device. We have the thing that Mohammed's using now with the neck spin that gives us pulse pressure and pulse pressure variation and stroke volume variation. We have available to us several toys that you can use in any one of your patients that can assess this. Okay? So what we're going to say is if I've increased elastance, what's that do? Increase sympathetic tone or increase stiffness of the vasculature. And a decreased elastance is decreased sympathetic tone and decreased elastance of the vasculature. So here, now let's go back to the left ventricular pressure volume loop. Let me show you how it all fits together. And then at the end of this, I'll give you a really simple approach that works in every one of your patients. Remember, the left ventricle is its volume on the x-axis, pressure on the y-axis. Left ventricle fills to maximal volume and diastolic volume. Isometric contraction. The aortic valve opens, boom, stroke volume. The area in hindsight here is stroke work. Do an insystolic stiffness, the maximal insystolic elastance of the heart, which is a function of contractility, and the heart contracts. You with me so far? Yes? Okay. That's my stroke volume. And the maximal stroke volume that I can have would be if I had no pressure to eject against. If I had the left ventricle eject and cut the hole open, the aorta sitting right there, that would be the maximum stroke volume that ventricle would get. All right? You can only do it once because there'd be no coronary perfusion because I cut that open, but I could get a good beat. So the lower I make the left ventricular pressure for a given end diastolic volume, the greater the stroke volume. The more I increase the left ventricular pressure for a given end diastolic volume, the more the stroke volume will fall. Do you agree with that? So what would that look like? Okay. So if I increase the arterial pressure, my stroke volume falls. If I decrease my arterial pressure, the stroke volume goes up. You give a vasodilator to a person heart failure, your stroke volume increases, right? Okay? You know this. Okay. So let's plot what this would look like. If I were to plot arterial pressure versus stroke volume, as the arterial pressure rises, the stroke volume will fall. Yes? Didn't I just say that? You all with me so far? This is important. You got to follow this point. This is very important because this is going to be the basis. If I raise my arterial pressure, the blood pressure, the stroke volume falls. If I decrease the pressure the heart has to pump against, the stroke volume goes bigger, right? So that's what the curve would look like. Okay. The maximal stroke volume I can possibly have is going to be a function of my end diastolic volume minus whatever the minimal amount that can't come out. This is my volume. There's a little bit of blood that's between my fingers. There's no way I can get it out. But other than that, that's the maximal stroke volume I can get. So it's end diastolic minus that little bit. You with me? Good. Okay. This occurs if I have a constant end diastolic volume and contractility. Well, remember my arterial elastance? That was a curve that went this way. Remember? Remember I said if the stroke volume went up, the arterial elastance. That means that in you and I, there exists one and only one stroke volume and mean arterial pressure we can have, which is a function of ventricular arterial current. It's a function of our end diastolic volume, contractility, and arterial tone. You follow what I said? You'd already seen this curve. That one I showed you in the last 15 minutes. So I'm just adding this one to it. You with me? So that means in steady state, we have only one stroke volume and only one mean arterial pressure we can have. So when I talk to you about looking at the arterial elastance, one of the ways to show it in the pressure volume curve is to start from the end diastolic volume through here. Now remember I told you we increased arterial pressure? And that caused the stroke volume to fall. Well, how did arterial pressure go up? I had to increase elastance. I had to make the ventricle stiffer. How else do you make arterial pressure rise, right? Give me a break. Give me an answer. How do I increase arterial pressure unless I increase tone for the same stroke volume, right? I have to. Okay? And how did I cause the blood pressure to fall? By decreasing tone. So yes, I did cause these things to happen, and I proved to you it worked, but the way I did it, I had to do it, was by changing the arterial tone. How else could I have had a change in arterial pressure for the same end diastolic volume? Well, that would look like this. An increase in arterial elastance. Remember, the increase in arterial elastance goes like that, and a decrease in arterial elastance goes like that. Remember? Remember that? Remember we did that already? I told you that was physics. So watch. This is a really important point. If the stroke volume goes down and the pulse pressure goes up, that's an increase in arterial elastance. If the stroke volume goes up and the pulse pressure goes down, that's a decrease in arterial elastance. Opposite changes in stroke volume and pulse pressure reflect changes in vasomotor tone. Okay? You with me? Opposite changes. And the driving thing is the pressure. Opposite changes in stroke volume and arterial pressure reflect arterial vasomotor tone. I think I gave that spot before. Okay? So, let's now increase contractility. Remember, we said when we increased contractility, we shifted and had a steeper insystolic elastance curve, right? So for the same end diastolic volume, higher blood pressure and higher stroke volume. Well, the reason blood pressure went up is you went up the same vasomotor tone, but I had a larger stroke volume. The stroke volume went up with the same resistance, the pressure has to rise, right? Okay. And if I impair contractility, we not only have a decreased stroke volume, but blood pressure falls. And you know that's true too, okay? So what would that look like? Well, that would happen on this curve. If I increase contractility, both mean arterial pressure and stroke volume go up. And if I decrease contractility, both mean arterial pressure and stroke volume go down. So let me go through this. If I'm looking at contractility, if the pulse pressure and stroke volume rise, it's an increase in contractility. If the pulse pressure and stroke volume go down, it's a decrease in contractility. Matched changes in pulse pressure and stroke volume can reflect changes in contractility. Okay? But unfortunately, changes in contractility take time. Define time. 30 seconds, a minute, 5 minutes. They cannot possibly occur on a beat-to-beat basis. What occurs on a single beat? Changes in preload from positive pressure breathing and spontaneous breathing, changing your end diastolic volume. So let's take a look at what happens with that. If I were to increase my end diastolic volume, I get a bigger stroke volume and mean arterial pressure for the same contractility. And if I have a smaller end diastolic volume, I'd have a greater one. So what this would do is give me a parallel shift of the curves both ways. It'll be the exact same effect of an increase or a decrease being an increase or decrease in volume, but I have to have a ventricular volume responsive. You with me? And these occur instantaneously on a beat-to-beat basis. Okay? So let me go give you some real examples. I've got a person with a mean arterial pressure of 70 and a stroke volume of, let's say, 20. And I get a fall in my stroke volume and a fall in the blood pressure. What must that be? I have a decrease in stroke volume and a decrease in blood pressure. Both going down. That has to be decreased contractility. Okay? And if I see the blood pressure go down but the stroke volume go up, what must that be? What? Vasodilation. Yes? Okay? And if I see no change at all in mean arterial pressure, but stroke volume went up, two things had to happen. If I've got no change in blood pressure, but stroke volume increased, two things have to happen. Because all I had was an increase in contractility, blood pressure went up. Yes? So I had to have vasodilation as well. What drug causes an increase in contractility and is also a vasodilator? No, dobutamine. And that's what you see with dobutamine. Okay. Now, if I have no change in stroke volume, but the mean arterial pressure went up, two things had to happen. I had to have an increase in vasomotor tone, but if I had only an increase in vasomotor tone, I would have seen the stroke volume fall. So I had an increase in contractility and an increase in vasomotor tone. What drug increases vasomotor tone and increases contractility? What? Norepinephrine and norepinephrine. And that's exactly what you see. And finally, if I see that the stroke volume doesn't change, but the mean arterial pressure falls, I must have some form of loss of preload associated with the decrease in afterload matched. And that's what you see in nitrates. So everything you see with your drugs and your therapy can be explained by ventricular arterial coupling. Now that I've explained it this way, let me give you a really simple way of using it clinically. I don't care what your stroke volume and your pulse pressure are. My only question is, did your pulse pressure go up or go down in response to time or treatment? Did your stroke volume go up or go down from where I was? Okay? Everything I said simplifies down to this graph. If I see in my patient that both the pulse pressure and the stroke volume go up, what's happening? What things are happening? What things could cause that? Contractility, volume loading, and that's what we see with increases in catecholamines, volume loading exercise. And if I see both the pulse pressure and stroke volume going down, both together, what's happening? Those are the bad things, right? That's the shocks. That's hemorrhage, heart failure, tamponade. Okay? You with me? And, wait a second. How can I have the pulse pressure going up, but the stroke volume going down? How can I have them going opposite direction with the pulse pressure going up? What can cause the pulse pressure to go up and the stroke volume to go down? Vasoconstrictors. That's what we see with vasopressor therapy and with pain. And finally, what? The stroke volume's going up, but the pulse pressure is falling? How can I have the stroke volume going up but the pulse pressure fall? What possibly could be the cause? I can't hear you. Vasodilation or our enemy sepsis. And this works today when you go back to the ICU. Okay? This works today when you go back to the ICU. And it all based on the other figure I showed you and all the stuff I went to. You don't have to remember all the other stuff. That just proved to you that what I said was true. This you can use today in the unit. Okay? And it's that simple. But you have to understand that ventricular arterial coupling is determining the instantaneous changes. So, arterial decreases and increases with various things. In summary, the primary determinant of organ perfusion is organ perfusion pressure. That's why we define blood pressure more than anything else as the initial resuscitation goal. But once that's done, then we worry about flow. Flow keeps the pressure constant. That's its job in life. Pressure-flow relationships can be examined by mean flow, change in pressure to flow, and the zero flow pressure describes local control. Ventricular arterial coupling describes the matching of the heart with the circuit. And that's the way you need to think about it. Next week, or whenever we talk about effective circulating blood volume, we'll talk about venous return, which is the primary determinant of cardiac output. Venous return is cardiac output. They are the same words. They don't sound it, but they are. And I will give you clinical data on patients in sepsis and post-op who are given norepinephrine, published papers on that we studied, showing how it alters mean systemic pressure, the resistance to venous return, arterial resistance, and contractility, and how they all come together to show you exactly why some patients have an increase in cardiac output and some have a decrease based on the same increase in mean arterial pressure with the same drug. And you can explain it all based on the physiology. And the neat part about it is you can actually do this at the bedside using minimally invasive monitoring, but that we will go over in about a month. And with that, I'd like to thank you for your attention. I'll be glad to answer any questions you have.